Good afternoon, good evening, dear friends, for those who are in different areas of our continent. It is always a pleasure for us to meet. And in these dates coming close to World Hemophilia Day, we feel closer to one another and more united than at other times. But we all know that hemophilia and other bleeding disorders are an everyday topic for us all. Without further ado, I'd like to let you know that we have a presentation by Dr. Miguel Escobar. He's a very dear friend of the Coalition of the Americas who always supports us and provides guidance, and he enlightens us with his presentations. Thank you, Dr. Escobar. Welcome home as usual. Well, thank you so much. Good evening, good night. Good evening from Houston. I want to thank this group for participating. It is a pleasure for me to be with you again and talk to you about a specific topic such as non-factor replacement therapies. As you all know, there have been several presentations of other similar topics. But today we are going to talk about these non-replacement molecules. Thank you, Doctor. Dr. Escobar is the medical director of the Hemophilia and Thrombosis Center, Gulf States Hemophilia and Thrombophilia Center, and he's going to discuss new hemophilia therapies, non-factor replacement treatment. For this important presentation, we would like to thank our usual support, Cadium, Pfizer, and Biomarine, for the support provided to make this presentation possible. And I'd like to ask everyone to take into account that you need to choose the language that we are going to listen to the presentation. You can choose between English and Spanish. At the bottom of the screen, you will find a globe saying interpretation, and there you can choose English or Spanish. What's important is that you don't leave it in original language, because otherwise you won't hear the interpretation. I don't know how many people we have in the meeting. We have 28 people already having joined in. So, Dr. Escobar, we are going to start. Go ahead. You can start discussing this important topic. As mentioned, we are going to talk about non-factor replacement theory. These are my disclosures, mine and the university's. It is important to start by having a look at progress that was made in the past, in recent years. There has been very important progress from hemophilia management perspective in the past 10 years. As you can see, we had long-term factors. That is going to be a separate presentation that will be provided. And non-replacement molecules are the ones we are going to discuss today. We are also using ultrasound to evaluate or assess joints in many of your centers. And we have a new bridge agent, a new factor VIII recombinant, a factor VII recombinant, as well as a swine factor VIII that has been developed. And we have reached gene therapy. We are going to discuss hemophilia. Now my colleague will help you, Wade. She will write to you to explain how you can join. So here you can see plasma and cryoprecipitate. We are going to arrive at 2017 when the first non-replacement molecule was proved here in the United States. You know that it's emicizumab that is being used in many countries worldwide. What can we say about this molecule? It is a very safe and effective molecule which can be useful for patients for prevention, only used for hemophilia A. We will always have discussion topics. There is no equity from the point of view of patient care and treatment when we look at countries worldwide. This is one of the main problems that we face. Most of the people who are not receiving treatment are located in Asia, Africa, India, where actually most people live. And unfortunately, there is no availability. For many reasons, these people do not have the right treatment. Then there is the issue of prophylaxis. The dilemma is not that prophylaxis is approved or not. Prophylaxis is the standard treatment for any person with a severe phenotype. But again, the dilemma lies in availability of prophylaxis in our countries. Sometimes it is approved for some population groups, but not for others, or for some age groups and not others. Now, from the point of view of inhibitors, there is a lot to be learned about prevention and prediction, especially in hemophilia A with this new molecule. We see less inhibitors because they are beginning to be treated with this molecule to prevent bleeding. As to inhibitor treatment, we only have bypassing agents, as I mentioned, and there is a new factor 7A that has been approved recently, that is a bypassing agent, very similar to what we already had available in the market. As to the prevention of arthropathy, we know that prophylaxis is the right choice, but there are many things that we do not know about arthropathy, especially with these new molecules. Are we really preventing arthropathy or not? People who already had damage, what is going to happen with them if they use this molecule? Well, that's what we are trying to find out. And of course, the cost is something that will be discussed because there is a significant variability in terms of the cost of these molecules. This is just to remind you that we still have several topics that are still controversial, and there is a significant variability between the different countries. So what is the hemophilia target? To reach health equity. For instance, if we look at our patients' outcomes, men or women with hemophilia, and then you have the target of the treating physician or the multidisciplinary team. The target will be the same. The ideal would be the cure of hemophilia. But then we have to discuss health equity again, and we want to reach functional cure. The ideal is for patients to have normal hemostasis. Little by little, we have been moving in this direction. At the beginning, factor was provided when the patient was bleeding, while now we are preventing bleeding. In this graph, you can see that in the 1970s, we started with standard half-life factor, providing treatment 2 or 3 times a week. Then in 2014, we had extended half-life factor, and in 17, the non-factor replacement therapies. And now we have gene therapy that has been approved in several countries. What does this mean? Well, the person is developing their own factor and maintaining a constant level. They do not have peaks. We are talking about much higher constant levels of factor. That is what we want to reach, this hemostatic value and balance where the person does not need to worry about how much factor is being produced because the person is constantly producing it. Another area that is still controversial is the minimum level, the trough level, the minimum required, for instance, to prevent bleeding in a person's daily life, a person that can go to work and do their usual activities, everyday activities. What is the minimum level to prevent bleeding? Well, we do not know that specifically. We have some idea. There have been some studies, and we know that the higher the level, the better. We used to talk about 1%, and now we are talking about over 15 to 20% levels to have a fully normal life without bleeding. That is what we want to reach as a target. We continue to have this kind of treatment nowadays, depending on the activity and the circumstances. We increase or reduce the level. A person who is resting will require lower levels, although there may be spontaneous bleeding as well, while a person who is exercises or doing some kind of physical activity will require a higher level to prevent bleeding. So what matters here is prevention. The person should not bleed. That is something that we should forget about, that the person with hemophilia should bleed. That should not be the case. As long as treatment is available, the target should be 0 bleeds, and that is what we should try to achieve. Once again, we have that 1% level that used to be acceptable is no longer acceptable. Now you will see that in guides, the 1% level is no longer acceptable. We need much higher levels so that people with hemophilia will not bleed. And what is that level? Well, unfortunately, we do not know exactly, but based on studies conducted, if we look at this chart, we will see that if a person has a 1% level, the person will have 6 bleeds per annum. That is too many bleeds, and that's unacceptable. Once again, we need to lower those bleeding rates. This new study showed that if the level was 5%, there would be 1 bleeding per annum or 2. Is this acceptable or not? Well, it depends on circumstances. As a treating physician, as a hematologist treating patients every day, it is not acceptable for me to have 1 bleed per year. If they tell me that it's traumatic, okay, I can accept it, but a spontaneous bleeding is still too high.
Ideally, there should be no bleeding, and in the same study, it was seen that with levels above 12% on an ongoing basis at all times, that threshold where the patients stop bleeding. I mean, patients with hemophilia, I mean. So the target would be achieving that 12% or even higher, which is definitely difficult using just the factor because of the cost and because of the number of infusions and the like. So it will be difficult to achieve this, but possibly there may be molecules with a longer extended life which cause that. There's a new molecule launched last year for Hemophilia A, where certainly the levels are above 12% 70 days after the infusion. So we are close to that. Now, this is a model to show you the joint damage that takes place, which is directly related to the number of bleeds. If we look at the top part of the chart, a person who suffers from severe hemophilia and is treated on demand will have 1,500 bleeds throughout his or her life. That's unacceptable. That person will be completely disabled. Now, if we start at a low dose twice a week, 2 units per kilo, 10 units per kilo, the bleeds are reduced by half, but 700 is still too much for a person. if we increase the prophylactic treatment and we administer 25 units per kilogram 3 times a week, the bleeding goes down significantly, all the way through to 85. But yet it's a significant amount of bleeding. So much higher levels, more intense prophylactic treatment is required rather than 25 units once a week. 3 times a week, sorry. We are talking about a patient with severe hemophilia, but it can, this is for hemophilia A, but it can apply to hemophilia B as well. It is also important to note that we have information available proving that prophylaxis reduces or it goes down as people ages increase. This is a study involving more than 2,500 people, severe hemophilia patients, and the use of prophylactic treatment went down with age. These are many variables included here. For those who were less than 12 years old, almost 95% were receiving prophylactic treatment. By age 40, these had gone down to 74%. And once again, there are many variables that may be accounting for this, but one of them is fatigue, because you are constantly infusing the factor every day, day in, day out, every 2 days. And there's also the question of factor availability, also priorities, activities change. And we definitely see that the prophylactic treatment decreases, and this may not be ideal because these people will start bleeding and suffer joint damage. The extended half-life, well, there are 4 different mechanisms in place. You will hear them in the other talk that will be delivered later. But as you can see, this mechanism is important because there are different options available that you will hear about later. Now, talking about non-replacement treatment options, these did not exist 10 years ago. See now the number of products available and how many of them are in a preliminary research stage. They are not yet tried in humans. They are being tested at the lab or on animals. This has dramatically changed, which is very positive. It tells us several things. On the one hand, money is being invested on technology in order to have better treatment options available. And secondly, people with hemophilia will have a wider array of treatment options available. There was the standard half-life factor, and that was the only thing available. Now we have all these new molecules and this new set of treatment options with a completely different mode of action. These molecules here are not replacing what is missing, factor 8 or 9. What we are doing is working on coagulation to introduce changes into coagulation that will reduce the person's bleeding pattern without the need to replace the factor. This is most interesting, and these mechanisms, we need to closely look at them and certainly perform the necessary trials, because as we introduce these changes, we have to pay close attention to there not being any adverse effects as there have been in other cases. And I will mention these briefly. I do not want to confuse you, simply this is the coagulation cascade. And as you can see, all of these molecules will act at different levels. I don't think it is worth explaining how this works now, but as you can see, all of these molecules work in different stages of coagulation, trying to strike a balance, which is the important thing to note. We know that in patients with hemophilia, there is an imbalance, a coagulation imbalance, because either factor 9 or factor 8 are missing, so the scale is tilted towards bleeding. As we make changes, the scale reaches hemostasis or reaches a sort of break-even point. So we have to start with the basics. We see here on the left the thrombin generation curve at coagulation test we perform, which shows us what the person's coagulation pattern is. This is a normal person with a normal coagulation curve. Most people who do not suffer from hemophilia will be in this range. Now, a patient with hemophilia, the curve will shift leftwards, and on the contrary, a person who suffers from thrombosis or who has clots, the curve will move rightwards. So most people will have a curve in this range. Now, if we go to the curves on the right, we see the normal coagulation pattern, the one shown in blue and green. But if it is a patient with hemophilia, the curve will shift leftwards. And if it is a person who he corrects himself, the patient with hemophilia curve will shift rightwards. And the person who is suffering from thrombosis will move rightwards. It is important to strike that balance, therefore, right, in order not to shift too much to the left or to the right. And here is where these molecules become important, and it is important to carefully assess them. If we sort of go too far in one or other direction, we can generate the opposite effect. A patient with hemophilia will suffer from thrombosis. So this is difficult, but that's what the coagulation tests are performed for, using these molecules. One of these studies may take 10 years from the moment it starts till it ends. It's 10 years before the molecule is approved. Indeed, most of the molecules that are tried are not approved. The percentage of molecules being approved by regulatory agencies is very small because of this very reason. I mean, we need to look into what the best mode of action, the best dose is. Sometimes they have too many adverse effects and they are not approved. That is why it is important, once again, to perform these clinical trials. Once again, when we speak of hemostasis in normal conditions, it's the scale that maintains a balance at all times. On the one hand, we have coagulation factors, 8, 9, all of them. And on the other hand, in the other part of the scale, we have the other proteins produced by the body, anticoagulants. Both strike a balance in a normal person, and we see here the normal coagulation curve. What happens in the case of a hemophilia patient? A patient with hemophilia will have one of the scales tilted to one side because there is a lack of factor 8 or 9. So anticoagulant agents have a greater burden, and that's why the person bleeds. And if we look at generation curves, we'll see that if this coffee-colored curve is normal, the patient with hemophilia will be below this level. That is, the person will not produce the same amount of thrombin as the normal patient. That's why the hemophilia patient bleeds, because they are unable to produce the necessary clotting to prevent bleeding. Depending on the level of hemophilia, thrombin generation will vary, but they will never reach this level unless they have a normal factor 8 or 9 levels. We have to take into account that all hemophilia treatment options, including factor 8, will bear an impact on thrombin generation. So if this is the normal curve, the patient with hemophilia will sort of go beyond the normal pattern. And if that's the case, we may cause thrombosis. If a patient with hemophilia receives a large amount of factor 8 or 9, that patient may suffer from thrombosis. That is something to take into account. And that's where all of these molecules come into play again. In this chart, for example, we see thrombin generation for the different molecules. This would be the patient with hemophilia. The lowest curve here, the flattest curve, is the patient with hemophilia. No thrombin is generated. But when we start using these molecules, they start generating thrombin. Similarly to a normal curve. We do not need to reach normal levels to prevent bleeding. However, this we have seen clearly. We see, for example, fitoserin, and the curve is halfway, but this is enough to prevent people from bleeding. So we have to bear in mind there may be the risk of thrombosis, especially when these molecules are used, which are different. Let's start with the first one, which you are very familiar with, emicizumab. Emicizumab is a molecule that is only used for hemophilia A. It may not be used for hemophilia B. What is the mode of action? If we take a normal person, a person with factor 8, this factor 8 brings together factors 9 and 10, brings them all together as blood flows. That's what factor 8 does, but in a patient with hemophilia A, they have no factor 8, so these factors 8 and 9 will never come together because it is factor 8 that brings them together. Since there is no factor 8, they will never come together and they will not be a way to prevent bleeding. When you administer emicizumab, this molecule here, it plays the same role as if the person did have factor 8. It brings factors 8 and 9 together and thus prevents bleeding. It is a molecule that is used, therefore, for a prophylactic treatment to prevent bleeding. It is subcutaneous, that's the form of administration. It can be administered once weekly, twice weekly, every 4 weeks. The half-life is very long, almost a month, so it has proven to be very effective. This is a summary of the trials involving emicizumab throughout the years. It was first used in adults and teenagers, then pediatric patients, children under 12, or then together or without inhibitors, and then to all patients. This is a molecule, emicizumab, which is effective for patients with hemophilia A, with and without inhibitors. It works the same for both. As I said, it can be administered once weekly, twice weekly, or every 4 weeks, but it's just for prophylactic treatment purposes. This is the pharmacokinetics, the curve in these patients, the molecule concentration throughout time. It remains stable, as you can see, at these concentration levels, provided it's administered at the recommended dose. Then the level will be maintained and thus prevent bleeding in these patients. Now, if we look at the annualized bleeding rate throughout time, we'll see that earlier on during the treatment, they had 2-3 bleeding episodes, but as treatment starts with emicizumab, we see the amount of bleeding goes down to 0 in many of them. So as they received this molecule longer, the bleeding episodes go down. We are talking about patients with hemophilia A, and we see here the proportion of patients who suffered bleeding. We see that as time went by, there was fewer and fewer bleeding. I mean, the percentage of people with 0 bleeding episodes reached 100%, some 80%, 82, 84%, 0 bleeding as time went by. So the longer they received the molecule, the more effective it appears to be. And partly this is because the joints no longer bleed, the person becomes more active, and the number of bleeding episodes goes down. So generally, it is a very effective molecule in all populations, I mean, ranging from children to adolescents and adults.
We observed that over 98% of the target joints that were constantly bleeding were totally resolved. So to summarize these clinical trials with emicizumab, you can see all 4 clinical trials here, and you will see there was a reduction of up to 96 or 98% of the number of bleeds. People had 0 bleeds. The percentage of them had 0 bleeds, or else the number of bleeds was reduced substantially when compared with the previous treatment, the treatment that they used before the clinical trial. As I mentioned, this molecule is being used in several countries, and we have seen it is very effective. Now, with this molecule, you need to pay attention to side effects. What are the side effects that we found with this molecule? First of all, there were 5 cases of thrombosis, 3 cases of thrombotic microangiopathy, and what was seen rapidly that it was in patients with inhibitors who were using the activated prothrombinic complex, that is treatment that is provided to inhibitors when they bleed. When this was recognized, this molecule was no longer used, and we did not see any other thrombosis events in this population. So this was related to the combination of emicizumab with the other molecule. Now, there were cases where patients developed inhibitors against the molecule, against emicizumab. This was a very low number. I think there are only 5 cases reported worldwide after thousands and thousands of doses. So it is very rare for a patient to develop a specific antibody against this molecule. And there was one case of a child with a kidney problem, and that was the only thing that was reported with the use of this molecule. So it is an extremely safe molecule. The other molecule that is being developed in clinical trials is mimate. Again, this is another molecule very similar to emicizumab. It is also provided, it's intravenously with a long midlife. There are phase 2 and phase 3 studies with the use of this molecule. This molecule seems to be a lot more powerful than emicizumab. It joins factor 9 and 10 more strongly, and concentration levels seem to be lower to achieve a similar effect. So far, everything looks very safe and effective, but we still need some years to see when this molecule can go to the market. It has the same mechanism as emicizumab. This is very promising, but we need to wait for clinical trials to see how we are going to use it. But it seems that it is more powerful than emicizumab, though it hasn't been approved. Another molecule with a different mechanism is fitusiran. What it does is inhibit one of these anticoagulant proteins, an antithrombin, that also contributes to balancing. We have talked that in hemophilia, this scale is not right. It is not balanced. And fitusiran acts at this level in anticoagulation. What is good about this new molecule, unlike emicizumab, is that it's good for both hemophilia A and B, and also for patients with and without inhibitors. So all patients can benefit from the use of this molecule. This is a molecule that is only used for prophylaxis and not for acute treatment, just to prevent bleeds. It is administered subcutaneously, and based on what we have now, it can be administered once a month or even every 3 months. So a person may require only 4 infusions per annum of this molecule to prevent bleeds. These infusions would be subcutaneous. You don't even need an intravenous injection. It's subcutaneous 4 times a year, and that's enough to prevent bleeds. Again, these are the clinical studies, the clinical trials. But if we see thrombin generation, it is very effective if compared with a person with hemophilia who is not receiving anything. they are given this antithrombin, and this improves significantly. It's not 100%, but we do not need it to be 100%. With these levels, we see the patients see a reduction in their bleeding rates. It's a large program. These are the various clinical trials that were conducted, one for those over 12 years old with inhibitors. Antithrombin levels were maintained at 10%. There was a study with hemophilia A without inhibitors, levels of 11% were maintained, and there was a prophylactic study with levels of 11%. By maintaining these levels of antithrombin, this protein that we all produce in our liver, there were adverse effects. There was thrombosis in 2 studies, as you can see here, 2 in the atlas and 2 in the prophylaxis atlas. So when this was found, these studies were suspended. What was happening was reviewed, and some changes were applied in the protocol. And it was then that the FDA allowed studies to be resumed. But then antithrombin levels were not maintained at such low levels. Instead of having the target between 10 and 15, the target was 15 to 35%. And from then on, we have not seen any thrombosis cases. That is why clinical trials are so important. From the point of view of adverse events, thrombosis in 2.6% was reduced to 1.4%. There were patients with cholecystitis, that is to say, patients who had stones in their gallbladder and they were in their gallbladders hurt, and there was increased hepatic or liver enzymes. By increasing the level of antithrombin, this reduced 16% of patients who had developed cholecystitis went down to 3.8%, and with liver enzymes, 20% went down to 3.5%. So there was a direct relationship with maintaining those low levels of antithrombin. Trials continue nowadays. We are still including patients in these trials, and we're waiting for final results to see if this molecule gets approved or not. It is good for both hemophilia A and B, and these are the results. The latest results were presented early this year. You can see the annual spontaneous bleed rates. This was very low, 1.9 or 2 bleeds per year in patients with or without inhibitor receiving this molecule. And the annual joint bleed rate is extremely low, 1.9 to 2.1, for a total of 1.9 per year. That is also extremely low with this molecule. So again, I think it is very promising, and we are waiting for the final trial results. We are still including patients in these clinical trials. And then we have to wait for regulatory agencies to approve this molecule, which is effective both for hemophilias A and B with and without inhibitors. This is a molecule that is being studied in many places of the world, including Mexico, fitusiran. The other molecule that is also in clinical trials is marstacimab. Marstacimab is a molecule with a different mechanism of action. It's a non-replacement. What it does is inhibit the intrinsic factor pathway. So it is also a balancing mechanism. And this is also useful for patients with hemophilia A and B. It's dosed once a week. It is also subcutaneous. And so far, we have seen that it is very effective. There have been no thrombotic events reported so far. And as we can see, there is a significant reduction in the annual bleed rate before and while the molecule is administered. Again, it can be used for patients with hemophilia A, hemophilia B, with and without inhibitors. So it is also very promising, but we have to wait for clinical trial outcomes. We have another molecule, concizumab. Concizumab has a mechanism of action identical to the previous one, inhibiting the intrinsic tissue factor pathway, and it is also subcutaneous. This molecule is administered on a daily basis. It is a monoclonal antibody, and it also increases the generation of thrombin in these patients. From the point of view of efficacy, we can see a phase 3 study where the number of bleeds reduces in patients who were not in prophylaxis. You can see a significant reduction in the bleed rate in these patients. So it is a molecule that looks very effective as well. From the point of view of adverse events, in March 2020, these studies had to be suspended because there were 2 arterial thrombosis events and 3 venous thrombosis events. So these studies were suspended and comprehensive research was performed. And then the doses were changed for this molecule. And the FDA approved the resumption of this in August 2020. In August 2020, the studies were resumed and there were no further changes to the protocol afterwards. So we have to pay attention to the mechanism and how these molecules work, because this is a mechanism of action which is very different from what we are used to using, which are factor 8 and 9. So we found these problems with thrombosis in many of them, and that is the reason why we need to stop studies, research, and see how we can improve this situation. This is what has been done, and by making all these changes, the number of thromboses has been reduced. Again, these are molecules that will continue being studied to see if they are finally approved. The other molecule that is sort of a beginner, we are beginning to put patients in this or include patients in this trial. This is the serpin PC molecule. Here the mechanism is different. This inhibits activated protein C, which is another molecule involved in balancing coagulation. It is administered subcutaneously. It can be administered every 1 to 2 weeks, and studies look very promising. This study has been there for almost 3 years, and many patients have received it, and it's a molecule that is useful for both hemophilia A and B, and for patients with and without inhibitors. We see that with the information available so far, the annual bleed rate is reduced in 96% of patients. So it is extremely effective so far. These patients have 1 bleed per year with this molecule, and there is a 94% reduction in target joints. This is another molecule with a very different mechanism of action, but it looks very effective, and so far it is safe. Again, we have to continue including patients in the studies and having a look at effectiveness and safety, which is something that we always pay attention to, and we need to see whether this will get approval some point.
Here we can see that this is the beginning of this new age in terms of scientific developments. There's a significant number of options available now, and the positive thing is that trials are still on the way, that new technologies are being launched and developed. So this is very important because these are new treatment options for patients with hemophilia. They no longer involve the use of factor 8 or 9. We now have this whole new range of possibilities, many of which will become approved and will be commercially available. So this is what we call the gold age in the field of hemophilia because of the number of options and molecules available or undergoing clinical trials, and which look very promising. Having said that, I hope I have been able to give you a snapshot of what we have available today. And as I said, more and more molecules will appear for the management of hemophilia. We may now open the panel for questions, if there's any, and I'll try to do my best. Thanks very much, Doctor. Let's see, Isidro, how many questions there are. What good news you bring, Doctor. This golden age, we love it because many of us were looking forward to witnessing this, being participants in this age, and this is becoming a reality, which is very good. Isidro, I give you the floor just in case there are any questions. Thanks, Marta. Thanks, Doctor. We have a question from Juan Montañez. He's from Colombia. He asks whether a person who has undergone a liver transplant is a candidate for new treatment options, and if the answer is yes, whether it is possible to migrate to another country to obtain it. Yes, well, in all these clinical trials which are being carried out, the patients that are chosen follow certain inclusion and exclusion criteria. And for many of these, the liver has to be as close to normal as possible. If a person wishes to participate in the trial, first liver tests have to be performed to ensure there's no fibrosis, that the liver is working properly before the person being included in any of these trials. The tests have to be performed first, and we have to ensure that all the inclusion criteria are met. Great, thanks. There's also a question asking if a person receives factor 8 and interrupts this for some time when retaking treatment, can antibodies be generated? Well, this is a very interesting question. The patient with hemophilia, I mean, the development of inhibitors or antibodies in these patients will never be zero, but the more exposed the person is to the factor, the chances of developing inhibitors is far lower. In the case of an adult who has received the factor since young, the possibility of developing an inhibitor against factor 8 or 9 is very low. If compared to a newborn, a 1-2-year-old boy or girl who starts to receive the factor, and we know that inhibitors appear after the first 25-30 infusions of factor 8, that's where the highest risk is faced. And the more and more you expose the person to the factor, if no inhibitor is developed, the possibility of developing this later is lower. But having said that, the risk is never zero. I do have adult patients who have developed inhibitors after many years. but this is something extremely rare, and that is why it is important to be, we always measure inhibitors in our patients at least once a year. Now then, with this number of molecules, especially emicizumab, patients who are not receiving factor VIII, it is possible that if they have not received a sufficient amount of factor VIII, especially in the case of children, in future, if the child needs many factor VIII infusions, he or she will develop an inhibitor unless he has gone through the first 50 infusions. This is where we have to pay attention, and hematologists, treating physicians have to pay close attention and monitor inhibitor development. Thanks. Also, there is a question, when can we expect the new treatment options to be available in Latin America? This is the million-dollar question. If you look at emicizumab, it reached Latin America relatively quickly after being approved in the USA and Europe. The other molecules have not yet been approved. Of these, one, concizumab, has been approved in Canada for hemophilia B with inhibitors. That's the only country where it has been recently approved. Once approved for use in Europe and the USA, it all depends, of course, on the company producing the molecule and where it is to be brought, but it shouldn't take too long, because if these molecules have been approved, it's because they are effective and safe. Also, there's a question about the care to be taken by a patient suffering from severe hemophilia, because maybe there is some drug that cannot be administered. Well, generally, patients suffering from any deficiency, but talking about hemophilia A and B, it is important to prevent the use of aspirin and its derivatives, molecules such as ibuprofen, the non-steroid drugs. They may cause some bleeding in these patients, so we try to avoid using them. And also it is important to take into account the use of supplements, natural medicines, which may cause bleeding. They are substances that are sold without a formula behind them, and these substances block platelets. So they may increase bleeding in patients with hemophilia. These molecules are, for example, curcuma, ginkgo biloba, ginseng. These supplements or molecules may increase bleeding in a patient with hemophilia because they block platelets as well. So we have to be extra careful with these substances because, well, they may cause problems. There's a question about whether molecules such as emicizumab are used for prophylactic treatment only or for surgical treatment as well. They are used for prophylactic purposes, but certainly when we bring patients to surgery and they are on this molecule, we leave them on this molecule. If it's minor surgery, say for example, dental surgery or a biopsy with emicizumab, it's enough. If it is major surgery, a knee replacement or gallbladder removal or appendix removal, then additional factor needs to be administered, but we never interrupt the administration of emicizumab. We simply administer additional factor for surgery and shortly afterwards. But since emicizumab is still active, recovery will be faster, and maybe they don't need as much factor for the recovery standpoint, but it can be used in the case of minor surgeries without any problem. Another question here, it's long. I would like to know, in the case of hemophilia, severe hemophilia patients, if they interrupt factor VIII and they receive severe blows that cause bruises or dangerous bleeding in the central nervous system, if they have to use additional, factor VIII in addition to emicizumab in these cases, or whether they should be maintained on emicizumab and not administer factor VIII. Well, this is a very important question. Emicizumab is used for prevention purposes. When the patient suffers bleeding, whether spontaneous or because of trauma, anywhere in the body, a joint or wherever, factor VIII must be immediately infused. In our case, at our center, at least all of the patients who are on emicizumab receive have one or two factor VIII doses at home, so that if they have any bleeding episode, they infuse factor VIII to prevent acute bleeding and continue on emicizumab. But yes, they need to infuse factor VIII whenever there is bleeding in patients who are on emicizumab. Another question, is emicizumab good for von Willebrand type 3 patients? Well, interesting question. It's not yet been approved for that target population, but in theory, it should work. And there are patients right now who are being treated with emicizumab, patients who suffer from von Willebrand 3. This is what we call off-label use, but theoretically, it should work. And as I said, there are patients who are receiving this treatment and it appears to be effective, but it's not yet been approved for that purpose. In the case of children with difficult venous access, the application of a replacement factor is more complicated, or can you make any other suggestion? No, on the contrary. These are molecules that are most convenient for people with a difficult venous access, especially children. In the case of emicizumab, many of them are receiving these molecules since they are born or when they're very young, because it is a drug that is administered subcutaneously like insulin. No central line is required, no venous access is required. So the use of these molecule is very convenient when administered for prophylactic purposes, and they are all administered subcutaneous. And if there is bleeding, then you have to add factor VIII or factor IX. Very well then. These were the questions we had at the time of registration and in the chat box. I don't know if any participant has any additional query. Well, just in case there is any other question, can we take a group picture, Isidro? Please turn on your cameras so that we can see you and so that you can appear on the picture. In the meantime, we will wait to see if there are any other questions. Yes, we have significant turnout. Dr. Miguel Escobar always fills rooms. Dr. Miguel Escobar is today a medical member of the World Federation of Hemophilia Medical Committee, so we are very happy and honored to have him. Plus, there's the good news that he will run for the same position this year, right? So we wish you the very best. Well, it will all depend on the voting process, but yes, it would be an honor and a pleasure for me to continue representing you, especially the Spanish-speaking population. It would definitely be great for me to do so. We are going to vote for you in Brazil. Thank you. Well, there are questions that are being received, but which repeat what has been asked already. Is there any specific question? This one is, if a patient with severe hemophilia A and von Willebrand, which of the molecule would work best? There's a mic open. If the patient has hemophilia and von Willebrand, these are rare cases, but they do exist. There, we should see what is lowest, whether von Willebrand or hemophilia. If the factor 8 is very low, then a molecule like emicizumab might be effective. If it's the von Willebrand levels which are low, we should see whether a von Willebrand factor should be administered, but I should see or look into the levels and the response to the different molecules. Doctor, can you clarify here? There is a question saying that whether any of these treatments helps reduce the inhibitor. I think you did touch upon it, but could you shed some light on it, please?
Molecules do not act in the inhibitor as such. A person with hemophilia A and inhibitors will receive emicizumab. They will stop bleeding. That inhibitor may be reduced, in many cases even disappear. And in some, the inhibitor remains very low. But the moment factor 8 is administered, that inhibitor may be back, because see that there is immune tolerance for inhibitors that used to be done and is still done. But since we see less inhibitors, especially because of emicizumab, then we are almost rarely using this. But the moment we use emicizumab or fitusiran or concizumab, that inhibitor will not be excited by receiving more factor 8. Actually, the inhibitor may disappear, but it may reappear when exposed to factor 8 again. Thank you so much, doctor. Well, I believe that some questions are repeated, but most of them have been replied. So, doctor, we want to thank you so much. Now that we're going to celebrate the World Hemophilia Day, we send you our hugs with love. We all feel part of the same family. And doctor, we hope to see you soon in the World Congress. We hope to be able to greet you personally and always thank you for your support and how clearly you conveyed all of the information and this very good news. We wish you all a good night, good evening. Well, it's always a pleasure to participate in your events, and I do look forward to seeing most of you in Madrid in the World Federation of Hemophilia Congress. And thank you so much with the elections as well, doctor. Thank you. Good evening. Good night, everyone. Bye.